Good day, everyone. I am Christine, the moderator for this webinar. I welcome everyone to today's webinar, that is Demystifying CPT 99211 in 2025, a compliance-focused guide for coders and providers. I would like to introduce our presenter for today, Dawson Ballard. Dawson Ballard, JR, is a highly respected leader in the medical coding field, holding over 20 years of hands-on experience in CPT codes, ICD-10 CM, and HCPCS coding, auditing, and education. I would now like to hand over the floor to the speaker. Over to you, Dawson.
Thank you very, very much. I appreciate that. And talking about 99211, I often found that this code is often misunderstood, that a lot of providers do not either utilize it because A, they don't actually understand the requirements around it. They don't understand what it is. They don't understand the documentation requirements or scenarios that they can use to apply this code. And we know that CPT defines that code as an office or other outpatient visit for the E&M of an established patient that usually does not require the presence of a physician. So many physicians still struggle with when and even why to report this code. So I'm hoping today to describe how to accurately report this code and how to provide some specific guidelines and examples that can help providers identify the appropriate use of this code. So what exactly is CPT code 99211? And a lot of times we often refer to this as being the nurse's code, the basic guidelines and the criteria that is needed to bill for 99211. 99211 is on the list of telehealth services. It has been made permanent by CMS. So who can perform 99211 services? Well, again, it can be a licensed nurse. Now that can be RN or LPN. It can be a PA or an APP. Some common scenarios that you could find for using 99211. It could be a simple wound check. It could be suture removal. For documentation requirements, we know that there are no key components at all that are required for the use of 99211. Medicare has some very specific guidelines for the use of 99211. It usually falls under what they call the Incident to provision. So what Medicare specifically says is the physician has to have initiated the care plan. The physician must be present in the office suite during the service. The visit must be medically necessary. Common mistakes to avoid: billing for routine tasks, and also lack of documentation proving the medical necessity. Now let's talk about the difference between 99211 versus, let's say, a 99212. Some best practices. Always verify the patient status. Again, 99212 can only be utilized, or 99211 rather, can only be utilized for an established patient. So the patient status should always be verified prior to the initiation of the service. The provider qualifications should always be confirmed. We need to ensure that medical necessity is documented and that we only use 99211 when there is no other E&M code that applies in that particular situation. So to kind of put all of this into perspective for the last couple of minutes that we have here, 99211 encounters with Medicare patients or commercial insurance patients require there to be an established plan of care. The patient has to be established. Medical necessity has to be met. Generally, physician presence is not required in that particular situation, although the physician does need to be present, if possible, in the office setting. Don't be afraid to use 99211. So appropriately reporting 99211 services can also improve documentation in a practice. I appreciate you joining me. I know it was kind of short and sweet today, and I greatly, greatly appreciate you joining me today.
Thank you, Dawson. That concludes the session for today. Thank you everyone for participating. You may all disconnect now and have a great day ahead. Bye.